Good morning, everyone. Welcome back. And on behalf of myself, Donna Ferguson, and my co-chair, Andrea, I just want to say thank you, along with the rest of the committee, for the great work that was done yesterday, the entire planning committee as well. I want to thank all the presenters, each and every one of them. I think we really had some robust conversations yesterday. And we heard from a few older adults who really gave us insight to their lived experiences and how they're impacted by the healthcare profession. We also heard from the engineering students who worked with older adults to match interventions. When we talk about what matters most to them. And at the end of the day, everything that we do, what is the most important is what matters to those in whom we serve. Also, we heard from the interprofessional roundtable exploring the WHO's model of care on intrinsic capacity and how we might apply it in an expanded view and an intrinsic capacity to the health profession education. Because anything that we do, we really want to make sure that our health profession is qualified to do well and serve our population well so that we cause no harm. And so along with that, that brings me to the point where we will explore the workforce challenges before we move into our breakout groups, because there's going to be some robust conversations there as well. So we're looking to hearing what happens in the breakout groups, being able to bring those back together. And without further ado, I'd like to introduce the moderator of the next session, looking at the supply and demand workforce, issues for ensuring an adequately trained health workforce, prepared to care for the many and varied needs of our older adults. And is none other than Dr. Greg Hartley, who's the Associate Professor of Clinical Physical Therapy and Medical Education at the University of Miami Miller School of Medicine. Much of his work and research is focused on geriatrics and the interprofessional education and care. Dr. Hartley, please unmute and the floor belongs to you.
Thank you, Donna. I am extremely pleased to be here with all of you, and thank you for joining us. Today's session is going to have three parts to it. This morning session, that is. The first is to get a sense of the quantitative sense of really the demand side of the equation. So that is the current and future projections of how many older adults there are and how many there will be in the future, who's taking care of them, and who is preparing the healthcare workforce, however we define that. The second part will be a description really of the supply side. So with really a focus on some of the barriers related to the supply chain and an emphasis on ageism. And then the third part will be a panel of experts in gerontology from a variety of different healthcare professions who work in education of those professions, and they will reflect and build upon what has been discussed in the previous two parts. So Hannah, I think what you have up right now is my slide deck, which is actually the second one. So if you want to pull up Rebecca's first. I will start with Rebecca George. And Rebecca will kick us off. She is a third-year medical student at UC Davis with a 15-year background in consulting for government, healthcare, and community organizations. You can read more about Rebecca's work and interest in her bio, which is located in the agenda packet. Rebecca will be providing us with a snapshot of demographics related to older adults, as well as available data points regarding the practice and education workforce focused on working with older adults. Rebecca, the floor is yours.
Thank you so much, Greg, and good morning. Welcome. Thank you for joining us. I'm very excited to be kicking off our conversation on supply and demand with a little bit more of a human look at the data that's driving this discussion. So when we look ahead at our conversation, we're going to be looking at how the U.S. population in particular is to be as well as what health conditions will be emerging. We're going to be looking at the role of the lay caregiver and the responsibility of that, as well as who's been giving and receiving care within that perspective. Then taking a look at how the healthcare workforce is changing, where healthcare training stands, and then seeing where do we go from here. So I want to just kind of frame this data and really acknowledge that meeting the needs of older adults is a global, international, interprofessional issue, and that the data that we're presenting here in terms of population is specific to the United States, just due really to the constraints of only having a few minutes to present on this and wanting to be able to give a little bit of a deeper dive. So how is the US population changing? So presently we have 330 million people, but over the next 40 years, we anticipate that that's going to grow by 22% to 405 million. And when we think about what that 405 million looks like, the demographics of our population is really going to be changing too. So we're going to see a 39% increase in the age of the community that's 65 and over, with an amazing almost 400% increase in our community of centenarians. From a racial and ethnic perspective, we see that we're really increasing across the board in terms of our diversity, and that many people are going, as they already do, multiple racial and ethnic identities, and that will really become the majority.
Brown, contributor to the New Yorker and author to the forthcoming book, The Outside Cat.
In terms of the sex ratio, which refers to the numbers of males to 100 females within the population, we see that, especially within the community of older adults, this is going to start becoming more balanced. And I just want to acknowledge that this data doesn't represent or include folks who are outside of this binary, although that community is very important to be recognizing and serving as well. Additionally, our labor force will be changing, with the greatest contribution of the labor force actually coming from adults who are going to be 55 and older. And altogether, what this looks like for us is that we're going to have a community that not only has 22% more people in it, but that are more advanced in age, more racially diverse, more gender balanced, and really an older workforce. And I think what this calls us all into is the opportunity for really amplifying cultural humility when we engage with our patients. So when we think about the health conditions that we'll be facing as we go forward, there's a number that really come to the top in terms of most common. And what we see overwhelmingly is that really—
I can't hear you, so don't worry.
Thank you.
Just one of those things.
What we see overwhelmingly is that Alzheimer's and memory care requirements are going to be advancing, as well as a number of common conditions that we see really across an older adult population: diabetes, stroke, heart failure, hypertension, and obesity, among many, many others. In terms of who's been receiving care, overwhelmingly, care recipients are female, are over the age of 75, although really what we see here is that care recipients are over the age of 50. Care recipients are receiving care and live either predominantly in their own home or with a caregiver, although, as mentioned yesterday by some of our community partners, 26% of folks are living alone. In terms of the needs that are driving this caregiving, None of these categories are mutually exclusive, just to make that comment on the data. Long-term physical conditions are the most common, with memory and mental health also making up a very significant portion of care requirements. In terms of who's been providing this care, the community caregiver is really a role that is increasing. We see that almost 19% of adults in the United States are already caregiving for a relative, which is an amazing number, and that this really is only anticipated to increase as we go towards that 22% increase in our population with an advancing older adult community. Additionally, we see that the person who's doing this caregiving is overwhelmingly a relative, which can include a partner, like the community partner that we heard from yesterday, PEG. Females are more likely to be caregivers, as well as people who are themselves over the age of 50. And within that, caregivers are more likely to be caring for multiple adults and for a significant amount of time, not just over 1 year, but often over 5 to 10 years. And we, of course, can recognize that the COVID-19 pandemic has really changed the landscape of caregiving in ways that we're still accounting for and are unfortunately outside of the scope of what we were able to present within this data this morning. So when we think about the healthcare workforce, it's definitely changing right alongside the population, but how is it changing? And the Bureau of Labor Statistics projects that over the next 10 years that we'll see a 15% increase, or 2 million job increase within healthcare, which is well over double the 6%, which is the national average for growth. And we see also that this anticipated growth varies greatly by discipline, from nurse practitioners, where we anticipate 40% growth, physician assistants, home health aides, OT, PT, behavioral health counselors, many disciplines where we anticipate that growth will be very significant. And I think it's interesting to note that when we get down to the bottom, physicians are the only category of health professional where the growth is not expected to even meet national growth projections. And that one of the things that's important for framing this data is that when we talk about growth of these fields, this doesn't guarantee that growth is meeting the demand. And the location of healthcare delivery is shifting as well. So we anticipate 37% more home care, as well as a big increase residential care home as the location where care will be received. And when we look at healthcare professions training, there's a lot of interesting things that we'll be able to explore here as well. So at present, the United States is home to almost 20,000 different healthcare training programs happening at nearly 9,000 training sites. And what we've learned is that more than 50% of those are programs that are really targeted towards physician residency or fellowship training, even though we just saw in some of the previous data that that's the community of health professionals that's anticipated to have one of the lowest areas of growth. And within the last year, we had almost 80,000 professionals who were pursuing faculty development training. And as has been discussed in the session yesterday, we know that having adequate faculty is essential to having mentors that can provide geriatric and older adult care. And additionally, almost 1.5 million professionals pursued continuing education, although the data behind what that continuing education actually looked like ends up being a little bit disappointing, where we see that although there were nearly 9,000 continuing education courses offered, only 5% of those were specific to geriatric health. And although the data that we have on is limited, we know that this sort of 5% number really remains in the ballpark for what the percent of health professionals from different disciplines going into geriatric health actually represents. So with that, I turn it back over to you, Greg, with this question of where do we go from here?
Great. Thank you very much, Rebecca. And Hannah, if you want to pull up the other slide deck now. So Rebecca really teed us off with the demand side of the equation. And I think we might need, there we go. Perfect. So what I'm going to talk about just briefly now is sort of the supply side. That is the supply of healthcare professionals, with acknowledgement that a lot of healthcare is done by non-trained lay individuals, but the emphasis of this part of the presentation will be on those trained healthcare professionals. So next slide. So again, as we have talked about, this session is about the supply and demand. Rebecca really got us started with the demand side, so I'm going to focus on supply. Next slide. I want to highlight 4 really big barriers that I think are present in increasing the workforce supply related to caring for aging adults. There are certainly more barriers than these 4. But I'm just going to highlight these. I'll focus a little on pandemic, financial barriers, ageism, which will probably be an emphasis because it's a passion of mine, and also curricula in health professional education programs. So next slide. So the first is around the pandemic, and what we have here are some data from Kaiser Family Foundation that's fairly recent that shows us how the workforce changed as a result of the pandemic and where it stands today, or as of summer of 2022. And what you can see is that those blue lines in those 4 settings have largely recovered, at least in terms of the workforce and employment, whereas the red and yellow lines have not recovered and are really suffering tremendously. And if you look at those are obviously nursing care facilities, which have suffered the hardest or worst, and community care facilities for the elderly. So this long-term support services really has exacerbated some pre-existing shortages that were there and made it much worse. And these settings have not recovered nearly as much as the other settings in healthcare. Next slide. The second barrier I'll highlight is the financial barrier. And here I'm talking about, there's really 2 sides to this equation. Obviously, there's the what society pays for in terms of care. And there's also the earning potential of those who work in the healthcare workforce. And just as an example, geriatricians in medicine compared to other medical specialties are at or near the bottom for out of 30 different medical specialties or subspecialties. Compared to all those different specialties, geriatricians are, in terms of income, near the bottom. And there is systemic ageism, I think, embedded within some of the financial part of that equation. And that is that society pays for what society values. And I think that's a bigger question than we have time to really get into today, but it's part of that financial equation. The third barrier I'll bring up is ageism. And this is no secret. So if you'll go back to that slide, that was the previous slide, thanks. The first is an acknowledgement that we're all ageist to some extent. And that is really particularly true in Western cultures, and most especially true in the United States, where we're indoctrinated with ageist images and beliefs from really very, very early childhood. If you think about even nursery rhymes and fairy tales and road signs and things that we see from very early ages, this is part of how we are really indoctrinated into the belief that aging is a bad thing. We spend $68 billion on anti-aging, which isn't really even a thing, right? You can't not age. So it's really interesting how this country really approaches its attitudes and beliefs around ageism, and it infiltrates everything, and is, I think, particularly relevant as we go dig a little bit deeper into the supply of healthcare professionals. Okay, now next slide. So not only is it just bad for the healthcare professions, as we'll see in a moment, but it's just bad for health. And so there's been some really interesting research done lately that if you have positive beliefs about aging, if you just think getting older is a positive thing, then you are anticipated to live as much as 7.5 years longer than individuals who have a negative view of aging. This research done by Becca Levy was just published in a new book she has out called Breaking the Age Code, and is supported by some additional research that's cited there at the bottom of the slide. Now, the top of the slide that I sort of brushed over or skipped, actually, ageism manifests itself in a variety of ways. And if you look at the different healthcare professions, I'm a physical therapist. And so when I think about how ageism is manifested within my profession, I can think of a clear example, and that is underdosing exercise, assuming that individuals can't lift more weight because they're older, assuming people can't do more sets or reps of an activity or walk farther because they are of a certain age. And that assumption leads to this systemic chronic underdosing of exercise, which in turn creates a worse outcome for the individual. In medicine, maybe attributing causation to an ailment to age alone. Your hip hurts, what do you expect? You're 75 years old, right? Case managers, maybe suboptimal placement, then an implicit belief that if you're 80, you don't have much potential and maybe you don't belong in a more aggressive setting. And in clinical research, just outright exclusion from healthcare research of aging adults. Now, the FDA, in terms of drug studies, have made some recent changes to ensure inclusion of older adults, but that's fairly new. For many, many years, even drug studies excluded the people who, by and large, use the medications. All right, next slide. The World Health Organization has recognized ageism is a problem, and in 2021, created a campaign to tackle ageism. I encourage you to go to their website and search for campaign or ageism. You'll find lots of really great information written in easy to read format in multiple languages. And what you see on the screen are some social media images that they have as part of a media packet related to this campaign. But again, just a recognition that ageism is affecting outcomes, life expectancy, and health worldwide. This is not a problem that is unique to the United States. Every country has its own unique nuances related to ageism, and I think it's exacerbated in some countries over others, but it is a worldwide issue that the WHO is paying close attention to. Next slide. Now, in health professional education curriculum, this is sort of the fourth barrier that I mentioned at the beginning. Often there's no required course in geriatrics, even as almost every health professional who works in the healthcare field will work with this group at some point in their career. It's often not a course that's required. Pediatrics usually is, even as though only a fraction of healthcare providers actually ever practice in pediatrics. I did a couple of surveys and some data that I found or had access to, and the most recent data I could find for my profession was from 2015, and 42% of PT programs had a dedicated course in geriatrics. And in medical schools, this was fairly recent. I just found from a couple of months ago, 76% of medical schools provide an optional clinical experience in geriatrics, so they have to opt into this. And only 45% of programs required a geriatric rotation. And a couple of interesting quotes here. One from Louise Aronson, who wrote a book called Elderhood. I encourage you all to take a peek at. There's a belief that aging adults are just adults with more years of experience, and not an understanding that there are three phases of life: childhood, adulthood, and elderhood. And each of these are distinctly different. And then last, a physician from USC, we graduated medical school lacking confidence about how to manage pain in a 90-year-old cancer patient. Drug interactions and dosing adjustments for the elderly get short shrift. Family practice doctors often know more about rare pediatric genetic diseases than they do about clearing an elderly female for surgery. Next slide. So there is influence of ageism within the health professional education curricula. Ageism itself might deter students from wanting to work in geriatrics or in gerontology altogether. That is probably the result of growing up in an ageist society, especially in Western countries and cultures, I think. There may be implicit or even explicit bias among faculty in HPE programs, health professional education programs, where faculty may even say, oh, why would you want to work in that area? It's boring, it's depressing, patients don't improve. And AAMC in 2018, the Physician Specialty Data Report found that the number of first-year residents and fellows studying geriatrics declined by 14.3% between 2012 and 2017, which was the most recent data I could find. So the problem's actually getting worse, not better. Next slide. So let me wrap up with that. And hopefully I've introduced a few concepts that I think contribute to the supply side of health professionals being able to manage and take care of our aging adults. So with that, let me ask our roundtable discussants to turn your cameras on. This includes Lauren Mazurko, Ryan Bradley, Rajan Moon, and Janine Lawrence, and Barbara Resnick. If you guys want to get your cameras on, I'll start the conversation with our participants. So I laid out a number of barriers that could hold learners back from pursuing further education in gerontology or prevent providers from engaging with older adults in ways that could promote healthy living. So we'll turn now to our roundtable discussants for their perspectives. I'll start with Ryan Bradley. Ryan is Director of Research and a Senior Research Investigator at the Health Gut Research Institute. He brings a public health and integrative health perspective. And Ryan, can you talk with us about your experiences, be it as an educator or personally, about whether situational or experiential learning has had a positive or negative effect on learners' interest in working with older adults?
Yeah, hi, good morning, everyone. And thanks, Greg and the organizers. I appreciate the opportunity to share my thoughts on this topic. In general, I consider situational learning to be vital to the clinical education experience. In my experience as a clinical educator of medical students and residents, situational learning, specifically medical students training in primary care delivery to older adults in a community-based setting, has had a strong and positive impact on learners' interest to go on to work with older adults in their careers. My opinions are based on my experience as an attending physician in an integrative primary care clinic that was nested within a community-based senior center in Edmonds, Washington, which is about 20 minutes north of Seattle. At the time, my university was invited to develop a clinic within the senior center because the senior center leaders recognized their community members had unmet needs. They had highly uncoordinated care and needed better guidance on nutrition, physical activity, and practical advice to improve their function, reduce risk of falls, preserve cognition, etc. My observations attending fourth-year medical students and residents in this clinic was that they found their care delivery experience to be highly rewarding. The patients that they saw were appreciative of having care providers listen to their stories, coordinate their care, and pragmatically address many underlying obstacles to improved health. The trainees left clinic each day challenged because of the complexity, but also with a high degree of satisfaction, feeling like they were doing good and really helping the older adults there. Two students stand out as particular case studies in which their situational learning experience during their training influenced the direction of their entire careers. One student, after witnessing the need for dementia care in older adults, went on to operate now both a clinic that specializes exclusively on cognition care, but also started a residential long-term care facility that incorporates many of the tenets of integrative medicine, including plant-based nutrition, combined cognitive and physical exercise, social support, and highly multidisciplinary care teams on site. And so it really completely altered her career. Similarly, another graduate entered clinic wanting to focus exclusively on what we consider some of the more traditional complementary medicine modalities, things like homeopathy, hydrotherapy, et cetera. But her experience in that senior care community clinic, in working with patients that had multiple chronic conditions, taking polypharmacy, usually without a care provider really managing their care, completely shifted her care and or her career. And she now runs an integrative primary care clinic outside of Portland, Oregon, that focuses almost exclusively on older adults with multiple chronic conditions. So these situational learning experiences, in this case, community-based integrative primary care nested within a community senior center, they're really pivotal for medical students to learn both the considerable need that exists for high-quality care for older adults, but I think even more importantly, how rewarding it can be to work with such an appreciative, responsive, and deserving group of people. Thanks again, Greg.
Thank you, Ryan. That exposure and integrated practice is essential to, I think, improving attitudes around that. Now, let's turn to Lauren Mazurko. Lauren is a geriatrician and medical educator at Eastern Virginia Medical School. Lauren, same question. Can you talk about your experiences and what inspired your learners to want to pursue further education and working with older adults?
Yeah, thank you. Hopefully everyone can hear me. More recently, I'm also the medical director for hospice and palliative care at the Hampton VA, in addition to my role at Eastern Virginia Medical School. And, you know, in that opportunity to work with learners across the continuum from pre-med, you know, within the MD program, mentoring, you know, undergrads, but then also working with our residents and fellows and colleagues out in practice, really finding out about their why. Many folks have had these close relationships with older adults in their life and maybe frustrated by the healthcare experience they had, or maybe inspired to want to learn more and do more, but not know how to do that. Really thinking about integrating and highlighting not only our satisfaction, we do have one of the highest satisfaction specialties in medicine. So I do want to say that surprises a lot of learners to hear that, and especially with the focus on well-being, self-care, and trying to find ways to make meaning and impact in medicine is something that we've highlighted and learners have been very receptive to also. But that being said, it can feel very overwhelming to take care of an older adult. We typically think about being very problem focused, whereas in geriatrics, we don't want to miss the forest for the trees and want to think about the bigger picture and want to think about how every element of their care, every element of the team really can influence, enhance function, independence, and all of those sorts of aspects that can make a difference in an older adult's care. And get back to what Ryan just said, where the gratitude and the satisfaction and making a big impact with seemingly small influence can be surprising to learners. And so seeing that in action, but then feeling empowered to take that, go back to other specialties. When they're on their surgery rotation, they bring up, gosh, I think this patient has delirium, and they're actually calling it delirium, not just altered mental status, confusion, and feeling annoyed, you know, with the 2 a.m. phone call. And so all of those things, allowing them to feel empowered if they choose a career path that is specific to geriatrics, which we know is limited in the specialty pathways in medicine right now, which I would advocate, similar to hospice and palliative medicine, we should open up more diverse specialty track pathways to get to care of older adults. But really thinking about the ways and empowering them in whatever field they choose to pursue, that there are ways they can influence, learn more, and be able to impact. And that can be through practice settings, program building. We think about all the age-friendly health system that we are hearing about, administrative roles like being a medical director and influencing and impacting and participating in teams, building teams, and in addition to the health system committee work and all those sorts of aspects. So I think it's surprising to learners to see the diversity of opportunity, but then allowing them to also see that just because someone has a problem list that's 20 problems long and they're on 43 medicines, we can take great care of those folks. And there's ways and frameworks to think about that.
Excellent. Thank you, Lauren. You've raised some questions for me, so stay tuned. I'm going to come back to you later and ask some follow-up stuff related to specialization in primary care, I think. But for now, let's go to Janine Lawrence. Janine is Senior Associate Dean of the College of Human Environmental Sciences at the University of Alabama. Although her specialty is nutrition, Janine has a lot of experience working interprofessionally. Janine, what has been your experience in understanding what inspires learners to want to work with older adults, both within and across professions?
Thank you, Greg, and good morning. Well, we know that working with older adults can be intimidating for the new learners in a healthcare field, particularly if that learner hasn't had any meaningful chance in their own lives to interact with older adults in a positive manner. Students may come into their health professions training with some pre-existing impressions that may not be positive. So the challenges that we have as educators are first in breaking any preconceived stereotypes, showing them that the older adult population is really diverse, ranging all the way from adults with healthy, active lifestyles to those that are in need of medical or supportive care. Second, we need to enhance their intentions and their enthusiasm for working with older adults. And finally, we need to increase their confidence and skills in doing so. So first, I'm going to talk about inspiring learners within their professions. One significant predictor of nutrition students' intentions to work with older adults is not surprising. It's their attitudes towards older adults. This has been shown to be consistent across disciplines. It includes social work students, nursing, OT, speech and language therapy. We're seeing it everywhere. So how do we influence and help those students develop positive attitudes towards older adults? We've heard a lot of this in the last 2 days. Providing frequent and quality interactions with older adults in a variety of environments is very effective in enhancing their attitudes. For our own programming perspective, this means us not having our students just go through that single rotation in the long-term care facility, but also having them work with community agencies that maybe support older adults in the lived environment, building opportunities into our didactic coursework for students to interact with older adults who are independently living and thriving in doing so. Additionally, we need to model the behavior that we want our students to aspire to, because it's been shown that subjective norms are also very strong predictors of students' intentions to work with older adults. When your students regularly see their role models, their faculty, their preceptors that are completing that specialized training, working with older adults in the field, and delivering coursework and educational opportunities that represent the fuller spectrum of aging, then those students not only become more comfortable in their own learning, but they develop the perception that those role models would approve of them pursuing a career working with older adults, and so they want to follow in your footsteps. Looking at inspiring learners across the professions, we need to train them in interprofessional teams in working with older adults. As was discussed yesterday, even with the move towards more interprofessional education models, the majority of students still learn in silos. This is really unfortunate given that we are expecting them right after graduation to jump into the healthcare field and magically know how to work effectively with other professions. And siloed education can give a student a false and very scary impression that they are all alone in developing a care plan, or that they need to know everything about everything, or just not knowing who they should turn to when a situation is not within their scope of practice. This can be a real deterrent to a student when they're considering a complex field like gerontology, particularly when they're not yet confident in their own skills. So a few years ago, we completed a grant-funded interprofessional training program to try to address this exact problem. We worked with teams of nutrition, nursing, social work, and medical students. In the beginning, we just put them in a room and had them discuss their scope of practice and their perceived roles within the team. This was a pretty fun meeting because we realized pretty quickly that none of the students had any idea what training and skills the other students had. Quick shout out, the social workers became the MVPs of the team. The teams then went out and worked with rural older adults over 6 months to assess and address their individual healthcare and daily living needs. What we saw with the students in this time was a rapid upturn in confidence in working and connecting with those older adult participants, and a building of reliance and trust in their own team. They no longer felt unprepared to meet the needs of the participants, but instead they had active team support and feedback, and they know exactly who on the team to turn to when there was a need identified. After that experience, they commonly reported that they felt more confident in working with older adults, as well as in working with other healthcare professions. So when we're trying to encourage and inspire learners to want to work with older adults, it seems that we need a multi-pronged approach here. Provide them with quality interactions with older adults, give them varied and regular experiences and training, provide and be good role models, and whenever possible, train them in interprofessional teams so that they develop the skills they're going to need with and with support from their professional peers.
Great. Thank you. Thank you, Janine. Now, I want us to consider the financial issues, and this is a complex concern. For this, let's bring Rajan Moon into the conversation. So Rajan is the Associate Director of Education in the Center for Healthy Aging and Innovation at the University of Minnesota. Rajan, could you share with us your thoughts on incentive structures for facilitating more in healthcare professions to work with older adults?
Of course, absolutely. Thank you, Greg, and good morning, everyone. As the director of an academic program that trains future leaders in senior care, this is a really important topic to me. And, you know, it's my everyday reality. We don't have long lines of students entering gerontological and geriatric practice. And so incentives, particularly financial incentives, are certainly important in our overall strategies to increase the workforce pipeline in senior care. However, I would caution that they're often seen as sort of a sole panacea, that a state legislature may create a scholarship program and all of a sudden magically all of the challenges are solved. And in practice, their success is often contingent upon other systemic factors and reforms. And incentives are not a new phenomenon, and they basically work by attempting to predict and influence human behavior. The basic principle that we as humans are driven towards rewards while avoiding negative experiences like sanctions. And so when I think of incentives in the senior care workforce, they tend to be a patchwork of state and federal programs that really differ depending on where you live. Many of them also tend to be under-resourced. But in general, they can be categorized by those that incentivize when someone is in school. So, for example, this could include scholarship programs and paid internships, which really help students gain experience working with older adults. And Janine did a great job of outlining the fact that this has been shown to increase attitudes towards aging and decrease ageism. The second would be for someone who's graduated, and paramount in this is loan forgiveness. And if you have been searching the internet or reading the news lately, there's a lot of discussion about federal loan forgiveness and whether or not we actually have that or can enroll people in it. Sometimes is confusing day to day. But many states have actually already piloted and implemented loan forgiveness programs targeted at senior care, particularly in rural or other underrepresented areas. And then another sort of grouping of incentives would be someone on the job. So this category of incentives really relates to that 6th recommendation offered by NASM in the quality study on long-term care. And if you haven't read that, it is a page turner. It is 600 pages of turning, but it has a lot of great information. And the quote that I would share is that the nursing home sector has suffered for many decades from both underinvestment in ensuring the quality of care and lack of accountability for how resources are allocated. Low staff salaries and benefits combined with inadequate training has made the nursing home a highly undesirable place of employment, made even worse in the pandemic. So these on-the-job incentives can include things like sign-on bonuses, increased wages, and competitive benefits. But bonuses are one-time injections to entice students, and the longer-term retention strategies such as wages and benefits are really part of a more complicated conversation about long-term care financing reform. In my state, for example, the average hourly wage for a direct care staff in senior care is hovering at $16 per hour. And you compare this to the starting hourly wage of a major retailer, which is $20 with full benefits, including tuition remission. So there are also incentives that have been particularly relevant during the COVID pandemic. A prime example is federal and state governments relaxing or temporarily pausing some of the regulatory barriers to obtaining the necessary certifications and credentials required to work in senior care. We can argue about the impact on the quality of care that these have, but they have provided some temporary boost to senior care. These are slowly phasing out, though some continue to be extended with an uncertainty for the future. So unfortunately, there isn't a lot of longitudinal literature on the effectiveness of these strategies. What is documented is that many incentives may provide a temporary boost, but longer-term sustainable change is a bit more nebulous, particularly within the context of a pandemic, which, as has been outlined, has disproportionately impacted senior care communities and resulted in significant burnout and turnover. So incentives like the ones I outlined aren't typically designed to tackle other larger systemic issues, some of which we've already mentioned, like ageism, immigration, migration from rural areas, reimbursement rates, and the sheer lack of a workforce, all which impact the senior care workforce. However, there are opportunities. Incentives are an acknowledgement that we have workforce pipeline issues, and we need to explore longer-term proven strategies to ensure a vital, robust workforce. So thanks for allowing me to provide some comments, and I look forward to our further conversation. Back to you, Greg.
All right, thank you, Rajan. Let's continue to build on this idea of incentivizing learners to work with older adults. Now we'll hear from Barbara Resnick. Barb, you're the chair in gerontology and the co-director of biology and behavior across the lifespan organized research center within the School of Nursing at the University of Maryland. What are some of the things that you've done or would like to do to incentivize learners and others within the nursing education community to want to work with older adults?
Yeah, so thank you. And I don't want to be redundant with everything else that's been said. So I'm going to be a little bit more blunt and pull it together. I'm probably the oldest one in the group. I fit in the older adult category, and I've been doing this teaching for a long time, both advanced practice nurses, physicians, all levels. I do a lot of interprofessional education, as many of you do. I'm going to be blunt. Change the law and you change behavior. We're dancing around what needs to be done. Everybody knows, we can all quote the statistics, the number of older adults is growing. I don't care what you do in healthcare. Even if you do neonatology, you're going to be dealing with grandparents. You need to learn about older adults, and it needs to be required across all areas. I will tell you what we did in nursing, and I lived through it, was at one point in time, we had a geriatric nurse practitioner, of which I am one. I'm a dying breed, okay? I gotta watch my certification or it goes away. We then pulled out the process and changed it and combined. First, we pulled out the geriatric, then we combined it back in, and we made it law in nursing. It is required. Every adult nurse practitioner needs to be adult geriatric, no matter where you work. We made it law. You have to do some work across multiple settings and certainly learn how to take care of older adults. This needs to be done across every discipline. And again, we talk, well, we integrate it through courses and whatever, people will work around it, but it needs to be required. So that's number one way to change things. And what goes with that is exposure. And I think everybody has kind of touched on that a little bit. But let's stop saying that long-term care is this negative, horrible clinical experience. It can be wonderful. It's our responsibility as educators to make it fun and make it wonderful. And that's where you change focus. And the third, job opportunity and job security. I let my students know, listen, coming in here, you may dream you want to work in this practice and that practice and this and that, but you know what? The only job, the only position, or the best position may be in long-term care. And let me tell you, in that setting, you're going to get to see diseases, you're going to have experiences that you never had, and you're going to have a team to work with, and you're going to be able to change how care is provided. Don't run away from what's bad, but make change. So those are really the three things that I think probably the group would also agree are important and useful take homes. I truly agree. Incentives are a short fix, a little Band-Aid, you'll catch a couple, but they'll get incentivized in one place and go down the street in 5 minutes. So those are my thoughts, and I'll throw it back to you, Greg.
Awesome. Thanks, Barb. Your candor has lit a fire, I think, in the chat, and you've got a lot of folks really excited about both your candor and your honesty, and I think calling out the need for legislative reform related to some of these issues. You're absolutely right. I see a lot of heads nodding on my screen. Related to that, I want to go back to something that Lauren brought up earlier, and that was around the notion of specialization or subspecialization in medicine in particular, where geriatrics is a subspecialty of either internal medicine, family medicine generally. And there are, I think, a lot of barriers for physicians to enter into geriatrics as an area of subspecialty practice for them. Other professions, I think, have created areas of specialty practice, whether it's in nursing, whether it's in physical therapy. I know some in my own profession, we have some of those things, but it still is a struggle, I think, particularly in my profession in physical therapy, to get folks interested in wanting to get specialized in geriatrics. So, Lauren, if you or Rebecca or Ryan, you folks being the physicians or soon to be physicians on our roundtable, want to speak to this notion of primary care versus geriatrics versus specialization versus subspecialization, and how you might perceive that to be a barrier, particularly in medical education, I think.
Yeah, I think that's a big question, right? It's one of those wicked problems, right? But, I think thinking creatively and being innovative, we have to think, differently than we've ever thought about how to train people in geriatrics. And there's big G geriatrics and there's little G geriatrics, just like there's big A advocacy and little A advocacy, but it all matters. And so some of the innovative ways that American Geriatric Society in particular is trying to work around the training pathways is thinking about integrated residencies and fellowships. So there are several programs now around the country where you track into internal medicine, family medicine, and you go all the way through fellowship in that program. So incentivizing folks and getting folks committed early, but they start to have some of those experiences from the very beginning of residency rather than waiting till after their residency is done and then doing specialty training in geriatrics. Similarly, one of the other barriers that we see, especially for folks who are already in practice, but now recognize the gap in their knowledge and skill set in caring for older adults. The challenge is taking the pay cut and going back to fellowship. And few people can do that. It's not logistically possible for most folks. And so again, innovative models that are evolving are the joint geriatrics hospitalist fellowships. There's also interrupted fellowships, meaning you're in practice and it may take you 2 years to complete the fellowship, but you can continue to work in between rotations for the fellowship. And so for now, until we can better evolve, as Dr. Resnick said, the competency-based education and required training across the entire continuum. In the meantime, these innovative programs are trying to bridge that gap and provide creative solutions to getting people trained up in the specialty, which is different than your other part of your question, which is about the competency to provide basic geriatric care. And so integrating required longitudinal courses through the medical education curriculum on normal aging, right? How much time do we spend on normal aging? We integrated a longitudinal course on aging and chronic disease that taught normal aging in all the organ systems, in addition to, showing how normal aging is different than disease states. And so all those sorts of things that, as was mentioned, need to be required and evolve, I think, are going to be further challenged as they're evolving in medical education in particular to shorten programs, going from 4 years to 3 years. Now you're compressing the curriculum. And so highlighting even more the need for education and awareness to be backed up further in the pipeline for undergrads, for, in high school, potentially learning about some of these things, because many of those folks are or will be caregivers, if at the very, least. So hopefully that answers your question.
Yeah,
I could talk all day about this.
I know. It's such an interesting topic. And I think in medicine in particular, it is a wicked problem, as you just described. And, you have pediatrics as a specialty area, yet geriatrics is viewed differently as a subspecialty area. And often I think in medical education, I know you work in hospice and palliative care, but geriatrics is so much more than just hospice and palliative care. And I think that there is a misperception, I think, among medical students. I don't know if, Rebecca, you have any comment on that or not.
Sure. I mean, I think that having early exposure within the curriculum is really, really key. And really, I mean, like so many people have already said, when we talk about medicine and medical care for older adults, we're really just talking about medicine. And obviously there are specifics to that population and that age group, but really that's an age group that everybody is going to encounter, like others have said, no matter what you go into. Mm-hmm. And I think integrating that early on within the curriculum is key, and really emphasizing within the curriculum that this isn't something that, you're, quote, going to get away from. And I think when we look at like the decline of people who are going into primary care specialties across the board, this really, really impacts the older adults. And there's a lot of complex factors that are driving that. We know, most people come out of medical school with upwards of $200,000 in debt, which is unfortunately, I mean, like we said before, you you pay for what you value, you invest in a strong education, and then going into a field that's going to make it challenging to pay that debt back over time is unfortunately a reality. And I'm very lucky to be in a program that really values primary care, but I also see that many of my colleagues, as we're now matching into programs coming up later this year in our last year of medical school, it's a concern for them. How are they going to afford to take care of their family? How are they going to afford to have a home and do basic things within the context of the undervalue of primary care overall across the board?
So I know that the last couple of minutes, we've really been focusing on really medical education and specialization, subspecialization. And, Rebecca, you showed us earlier in your demographic slides that, this is a tremendous problem. And certainly with the pipeline of predicted growth in physicians, which was abysmal, really 3% compared to other professions, the workforce is going to look different in taking care of aging adults. And health professionals are certainly going to be part of the equation, but I think a lot of care already is provided by lay people and untrained individuals. And so I'm curious to know if any of our panelists have any thoughts on the role of health professional education programs in training or helping to prepare a lay workforce, really, to deal with this gigantic bolus of individuals that is coming. So Barb, I see your hand up.
Yeah, I raised my hand for two reasons. Number one, absolutely, this is a big initiative I've seen in nursing. And I've always pushed, even in nursing schools, we should be doing family training. The expectations now on families are mind-boggling. But I think there's also the issue of families don't want to do it, and we assume they do want to do it, and we're going to have to work all that out. But yeah, absolutely, better training, and there's so much being done now on transitions of care. And nurses do also fall to be the ones to do that education, the teach back method, there's all kinds of things. And I think we're seeing a lot about cultural competence, understanding what's being said, but some of it is just straight up skills training. And what we really need to do is train more, for example, somebody who's in acute care or subacute, have family come in and do the care. And I remember, I'm the mother of multiples. I had triplets, and I remember going in every day and insisting that I be the one to bathe them and I be the one to do this and that. And now you have to advocate for that. So that's also something we need to teach families. The other thing I wanted to raise that we haven't raised is the whole issue of apprenticeship programs. And I truly believe somebody who started as a nursing assistant, because I knocked on the door of a nursing home and said, can I work? And got a job at 16 or 14, I think I might have even been. We're starting to see that again. And it's a history of medicine. It's a history of nursing. Forgive me, I don't know about PT or some of the other professions, but that may be coming. I'm hearing discussion about it in nursing. So just wanted to throw those out there.
I think you're right about that. Ryan, do you have something you want to add?
Yeah, thanks, Greg. I have a couple of thoughts. And, one is I just wanted to circle back to Dr. Whitwer's comments about interdisciplinary care teams. And I think that if interdisciplinary care teams, if we had more of them and they were developing coordinated care plans, I think that family members and community partners can be really instrumental in helping with implementation of those long-term care plans. And that said, I think that we also need to be really careful to not redirect the responsibility of healthcare and healthcare providers back to family members and community care leaders, because I guess it's just my bias, but I think, this is a responsibility of primary care, is to help patients navigate their specialty care and help navigate their long-term care. And, we have other individuals, other sort of subspecialty, not formal subspecialties, sorry, I misspoke, but new groups emerging in this field, like health coaches, for example, and health coaches have a very valuable role and could actually contribute to senior care in incredible ways if they were formalized and empowered to serve in this role of helping navigate these long-term care plans. So I don't want to pass more and more responsibility back to the family member, when really we have a healthcare delivery system and community that should be able to change and meet this responsibility through innovation and training. So is it important? Yes, it's absolutely important. I think that family medical visits are important. I think use of promotores in some in some cultures and the equivalent in other cultures can be very, very effective, and patients can trust them much more than they trust their care providers. I just want to be really cautious that we don't proverbially pass the buck of responsibility onto others.
I 100% agree with you. I think if you look at the mission statement of many of our professions, whether it's nursing or medicine or physical therapy or social work, you'll find society in there somewhere, the word societies, whether it's improve the health of society or transform society, which is part of the one for physical therapy. And I think we have to meet the needs of society, and this sector of society growing at the rate that it's growing, and given sort of the pipeline problem, I agree that we can't shift the burden onto the families, that we have a societal obligation as a healthcare profession to meet those needs. And as I said, that's sort of wrapped up in the mission of many of our professions. And so given that pipeline of folks who are interested in geriatrics is not growing to meet the need of the demand currently, I think some of the solutions really are around how we improve that pipeline, and can we improve it in time to meet the need for the anticipated growth in this population. And so there's kind of a crisis of time here, that I think there will be some short-term solutions, but I think long-term, we really have to look at how we get more individuals interested in working in this area of health. In the chat, there's been quite a lot of talk, I think, about early exposure in elementary schools, and getting kids exposed quite early to aging adults and the health professions around caring for aging adults. There's also been some talk about diversity and culture changes, and the diversity of the health workforce compared to, or I guess, next to the diversity of our society, because again, going back, reflecting on Rebecca's slides, that society, the aging society, looks very, very different, in 20, 30 years than it does today. And that also is wrapped up in some of the diversity things. Let me, I will open up the floor, I guess, for anybody that might have a question for one of our panelists. So if you want to raise your virtual hand, we've got, 7 minutes or so that we can spend just taking questions from you guys. So I see, I'm sorry, I don't know all your names, but maybe it's Abrizi?
Tabrizi, yes. Can you all hear me?
Okay. Yes.
Yes, Ryan, I think what you said is really is a fundamental issue that we have, that just passing the buck to others, and the with the population, as a dentist, with the population that I work with, and then they're especially in nursing homes, and memory care when the responsibility is passed on to the families. As we all know, the average time to care for loved ones is sometimes 5 to 10 years. We are opening the door to neglect because it's not intentional, but it's exhausting. They are not trained. There are a lot of personal emotions involved. There is far more elements into this. That is, if we are not at least we're not coaching them how to do it, we cannot pass it on to them. And I just cannot agree with you anymore. Thank you for making that point.
Yes, thank you for the comment. Any other questions from the audience? Anybody just want to raise their hand and ask any one of our panelists? Some of the comments in the chat are great. Some of them are long and I can't keep up with reading all of them, but there's been some good stuff there. Excellent. Yes, Shirley.
Hi, wait a minute, I gotta turn off. Okay. Oh dear. I wanted to ask about state policies that could be helpful with the workforce.
What policies?
State.
Okay. So, Rajan, I wonder if you might have a response to that. State policies related to the workforce.
Sure. So, thanks, Greg, and thanks for the question, Shirley. I mean, obviously, a lot of the incentive programs that are available are funded through, state legislative appropriations. As Barbara also said, that's kind of a temporary thing. It gives that little shot in the arm, I think, as I mentioned. The other one that I think has been really interesting is that this idea of relaxing some of the regulations. And it'll be interesting to see, again, the impact on quality. If we're allowing people to get, for example, a certified nursing assistant, their certification without going through all of the hoops, how does that in the end, face quality? States also really have key roles in just broader workforce development. So one of the challenges we have, and right now we have, almost 30,000 open positions in senior care in Minnesota alone, and 75% of our senior care communities have denied admissions because they don't have enough workforce to care for people. Not that they don't want to, but they're not able to because they just don't have enough workers. And this is because Minnesota has the lowest unemployment rate we have ever had in the entire history of us tracking unemployment. And so when you are fighting against major retailers and other employers, even other healthcare employers, we have some amazing healthcare systems like the Mayo healthcare system that have the ability to pay nurses double in their, primary care and acute care settings that we could ever pay in long-term care. So this is about really the very complex conversation about really changing the way we finance long-term care. I mean, we have to pay for the value of nurses. And I would just add in that not only are we up against ageism, we are also up against sexism because most of these positions are held by women. My PhD is in social work and most of my students are women. And in the program that I run, the long-term care administration program, over 75% of our students are students of color. So we're also fighting against racism. So these historically low reimbursement systems are for women of color who are working with older adults, who to me are, obviously we use the word heroes and probably shouldn't use that too much, but I mean, they are, they're caring for some of the most vulnerable. So the states have the ability to impact the conversation about workforce in general and incentives and regulations. So they're so important, but I would imagine the other panelists have some ideas from their states as well as regulations or demonstrations that their states have done.
Thank you, Rajan. I couldn't agree with you more. Those statistics from Minnesota are shocking, but probably not terribly different in many other states. I think Barb mentioned the need for legislative advocacy. And I think you have touched on that too, as well. For me, I think we are in this group of however many of us are on this call. A lot of us are educators and also work in a health profession, obviously. And I think that there's kind of a macro, a meso, and a micro level of advocacy that has to happen. And part of it is at the micro level within your own profession. And I think this speaks to Barb's sort of call, and everybody on the panel kind of touched on the need for changes in accreditation standards so that courses in geriatrics are required in every healthcare profession. We don't see that. And those sort of accreditation changes aren't legal. I mean, they are legal in a way, but it's not legislative in that sense. That's within your own profession. So I think we all have an advocacy role there within our own professions. At the meso level, there's the state legislation, right? And all of the things that can happen within our state. And then at the micro level, I think about federal legislation and how we finance long-term care or long-term support services at the macroeconomic level, whether that's Medicare, Medicaid, combination of both as it is now. So I don't know, how to approach some of those things is a lot harder. But certainly at the individual level, we have a role in all three of those. Ryan, let me let you make some final comments, and then I'm going to wrap us up. So go ahead, Ryan.
Rajan brought up the issue of not compromising quality as we consider some innovation in care delivery and making some of those credentials perhaps more accessible to others. And I couldn't agree more. I think obviously it's critically important when we talk about formal care delivery and elements of scope of practice and procedure and what have you. But I also want to just be careful with how we define quality. And that we're making sure that we're using quality in terms that matter to older adults and not necessarily in our sort of typical, process care metric, quality metric definitions of what constitutes quality. Because I guess I would wager, especially for things that really improve quality of life and function and experience of life and health, that a lot of our traditional quality metrics don't actually apply to what people care about the most. So I just think we need to be really cautious with quality as a quality as a barrier, and instead really kind of think out of the box around what training do they really need to improve health, function, and experience of life in older adults.
Absolutely, 100%, totally agree. And I think we heard this yesterday, and I know we're going to hear this after the break. It really does come down to what matters most to the individual, and those measures don't always fit in nice little quality improvement standards, right? So exactly, excellent point. Panelists, thank you all for participating and shedding light on your perspective on these issues and problems that I think do have solutions, but not easy ones. So with that, I'll back over to who? Patricia? Anna? I'm not sure. I know we have a break.
I'm here, Greg. Greg, thank you and Rebecca so much, and the roundtable discussants. I think some powerful things have been said today. You started out saying society pays for what society values. And I think that that's really critical, along with the fact that we heard change the law, change the behavior. So thanks so much to the team. What we're going to do now is we're going to take a 10-minute break. But what I want you to do is 5-minute break. See, I know you wanted 10. I want you to stay with me, just 5. And only because we want to be able to get you set up for the being able to go to your breakout room. So take about 5 minutes, but don't log out or anything like that. Take a moment to stretch, because I think the conversation is going to continue and they're going to be very robust and allow us to be able to set the stage or how we can affect change in the nation. So let's take that 5-minute break and we'll come back. Thank you.